My name's Dolores Pretorius. I'm a professor of radiology at the University of California, San Diego, and I'm going to give you a talk called Ultrasound Survivor on congenital anomalies of fetuses. My name's Dr. Pretorius. I'm going to talk to you about this little talk I made called Ultrasound Survivor, Congenital Anomalies. And basically, it's a little talk that I've made for you to kind of look at two pictures and see if one of them's better than the other and whether you'd like to be that one based on all these reality television shows. This is a picture of me going body surfing in a wave, and it's just like, you know, one of the things that you've got to balance your life, and it's something I've learned about only in the last couple of years, and I just wanted to share that with you. Okay, so this is a picture, and I want you, as the audience, whoever is watching this anywhere in the world on Sono World, to first look at it and think, would I rather be A or would I rather be B? And these are both anomalies of the fetus in the kidneys. So just look at it for a second. Think about what you might wish to be, whether you were A or B. Think of the possible differential, and then I'm going to tell you which is which. Okay, so the first thing you notice is that the one on the left, A, has multiple cystic components that do not connect, that are peripheral with increased echogenicity in between. That is classic picture for a multicystic dysplastic kidney. The one kidney on the other side has just a little tiny bit of dilatation, more normal looking. The patient in B has large echogenic kidneys, and I think they measured 6 centimeters, wasn't it? About 6.5 and 5.5 centimeters. And that is large for any time in gestation because a normal fetus should have kidneys that measure 4 to 5 centimeters at term. So these are large and echogenic and fairly classic for infantile polycystic kidney disease or autosomal dominant. So let me just tell you one or two things about multicystic cystic kidneys. First off, they do not function. They won't work at all. They generally involute over time. And the important thing to realize is that 40% of them have associated renal disease on the other kidney. They can have a ureterocele from like a duplicated kidney. They can have another multicystic dysplastic kidney, but if they have that, it'll be fatal because they don't function. Renal agenesis, if they don't have a kidney on the other side, then it's going to be fatal because they won't have any renal function. And then lastly, reflux. So perhaps this baby might have reflux, just a little tiny bit of dilatation, so that'll be watched. Most of these kids generally do well, so you would rather be A than B. Now, B was autosomal recessive polycystic kidney disease. And these are large echogenic kidneys. Excuse me. These are large echogenic kidneys that the babies end up with portal hypertension and often end up with liver transplants. 30% of them are affected and they end up dying as neonates. 50% of them will end up with end-stage renal disease or renal transplants in the first decade of life. And the appearance for autosomal dominant PKD is similar. So you always want to look at the mother's kidneys or dad's kidneys if you have him there as well to see if they have polycystic kidney disease. Okay, here's the next case. Would you rather be fetus A or fetus B? Well, we can see that the fetus in A has a monoventricle in the head with fused thalami. And this is very worrisome for alobar holoprosencephaly. The fetus in B has mildly dilated ventricles, so that these look like they're about 12 millimeter ventricles, and this is a case of ventriculomegaly or hydrocephalus. I guess maybe you wouldn't want to be either one, but probably most people would say B. Holoprosencephaly is a spectrum of disorders going from alobar, semilobar, and lobar. They generally have monoventricles, fused thalami. They often have facial anomalies, hypotelorism, cyclops, meaning one eye, proboscis, which is a fleshy mass above the region of the eye that looks kind of like a nose, but it's not a nose. And they often have midline, cleft lip, and palate. Anytime you see a fetus with possible holoprosencephaly, you should think trisomy 13. Trisomy 13 has polydactyly, so you want to go look at their hands and see if you can count the digits or whether they're clenched and you can't even count them. They can have large cystic kidneys that are usually echogenic. They have micronathia and congenital heart disease. Now, the other fetus wasn't so simple. It had dilated ventricles, but they were teardrop. And on this MRI, you can see it a little bit better, but it was on the ultrasound image, the teardrop parallel shape of the ventricles with elevation of the third ventricle in between. And this appearance of the teardrop is called colpocephaly, with dilatation of the occipital horns. And the frontal horns have this trident horn appearance, and that is classic for ACC. So let me go back and just show you the teardrops here on the original picture, that teardrop parallel picture of the ventricles. That's usually the one thing that we can pick up. Okay, this is another case. This is a trick case. So I just want you to look at it for a couple minutes. This trumps most people that look at it. So I think first thing you notice is that the baby on B, that this looks like a cranium with normal choroid. And indeed, this is a normal fetus, so you would rather be B. Fetus A is not the head at all. It's the chest. And this baby has bilateral pleural effusions with the spine over here to the left. Now, how do you tell the difference? Well, a cranium has calcification all the way around. An abdomen or a chest has a spine in the middle if it's transverse, but it doesn't go all the way around. So these are probably bits and pieces of the ribs, and these are the lungs, and the heart is right here in the middle. So what do you do when you think about pleural effusions? You think hydrops. Maybe this fetus has congenital lymphangiectasia with a cystic hygroma. So let's go upstairs and look and see if there's a cystic hygroma in the neck. Anytime you see pleural effusions, you should look and see if there's skin thickening for hydrops, pericardial effusion, ascites, or other markers or anomalies of aneuploidy. Okay, the next one. Would you rather be A, with this fetal head, or B, with this fetal head? Well, A is an encephalocele with a mass off the posterior part of the head, and B is a multiseptated mass from cystic hygroma and Turner syndrome. So what do I want you to know about encephaloceles? I want you to know that patients are often referred because of an elevated AFP, maternal serum, AFP, alpha-fetoprotein, that 75% of encephaloceles are in the occipital region in Caucasians, and 75% are frontal in Southeast Asian women. So we want to always look both anteriorly and posteriorly. And if you take folate prior to conception for future pregnancies, you'll have a risk that is the same as the general population for neural tube defects. Now, a cystic hygroma, what do I want you to know about that? Cystic hygromas are associated with aneuploidy or abnormal chromosomes in 50%, particularly Turner syndrome, as in this fetus, which is 45XO, and trisomy 21. These are often fatal, but this fetus actually survived, which is kind of unusual. And basically, if you see these cystic hygromas in the first trimester, they're more likely to be trisomy 21. In the second trimester, they're more likely to be Turner's, but they're both common. Okay, this is another trick case. So you look at the picture on the left, and then look at the one on the right. So the one on the left is an encephalocele with a mass behind it at the occipital region, so perhaps she was Caucasian. And then the one on the right is the uterus right here and the bladder with a big, huge fibroid in the LUS. So you would rather have a fibroid. This is the encephalocele on this baby. You can see that it is occipital. Okay, here's another case. Which femur would you rather have, A or B? A has an irregularity to this femur. It's not very sharp. It's kind of wrinkled. B, the femur looks normal, but when you look at the parameters here, the BPD is at 21 and 6 weeks, and the femur is at 20, so it's almost 2 weeks behind. So basically a short femur. So fetus A is osteogenesis imperfecta, which is a fatal abnormality in this fetus, and fetal B has a short femur from trisomy 21. So let me just tell you what I'd like you to remember about osteogenesis imperfecta. I'd like you to remember that they're short, irregular bones, that they have a wrinkled appearance, that there's asymmetrical shortening of the limbs. So you might not get the exact same on the right versus left because of they're related to all those mini fractures. That the ribs are often flared. See how they flare out? And that the thorax is small, the heart is a little too big for the size of this. If you can get pictures of the ribs, you may see the beadedness to them. But most often, from 2D, this is the type of picture we get. You can see the narrowing of the chest here as well. That's the thorax, and this is the belly, which is a little more prominent. Now, another really important finding for osteogenesis imperfecta is that the cranium is not well ossified, so it's easily compressible. When you push on with your transducer, it deforms the brain and then it pops right back up. And the other thing is that the brain is very well visualized as you look at it. It feels like you're almost looking at an MR. It's because there's not much cranium around it. Okay, on the other hand, what do you do when you have a short femur? Well, you go looking for other markers of trisomy 21. You look for a short femur, a short humerus, an absent nasal bone, echogenic bowel, nuchal thickening greater than 6 millimeters, an echogenic focus in the heart, and pyelectasis, which is just a little bit of renal dilatation, which has to be greater than 4 millimeters to be an aneuploidy risk factor. Now, how do you do this, looking for short femurs? We use this table from Nyberg et al., and we look at the BPD, and this is a normal predicted humeral length. And if the length is less than 2.18 at 4 BPD, then that is a short humerus. Here's a normal femur, and if it's less than this number, then it's a short one. Okay. Now, what are the anomalies you should think about for trisomy 21 or Down syndrome? First, you should think heart disease. Do they have an AV canal? Atrioventricular canal? Do they have a septal defect, either an atrial septal defect or a ventricular septal defect? Perhaps they have tetralogy of Fallot, all things that we can look for on ultrasound. Do they have duodenal atresia with a double bubble sign, esophageal atresia with polyhydramnios, mild ventriculomegaly, cleft lip and palate, unilateral pleural effusion? Okay, the next case. This is a patient that it's not an anomaly, but she comes into the ER with bleeding. Rule out ectopic pregnancy. This is a 3D picture showing the coronal through the uterus, and then where they've taken it from a transverse view, and then here is the multiplanar picture of C-plane through the uterus with this abnormality right here. Okay, so box A is A patient is interstitial ectopic and B is a normal. It just looks like this gestational sac is way out into the myometrium. So let me show you. First thing about ectopic pregnancies is that we have to differentiate whether we really have an ectopic or whether we just have a uterine malformation like a septate uterus that then has a sac in one horn. Notice where the interstitial ectopics lie, right here. And those are fairly rare. Most ectopics are going to be in the tube someplace. The unusual places for ectopics to think about today are in the cornea of one of those horns of like a septate uterus, in the interstitium right here at the level, or down in the cervix, or the C-section scar right in the cervix as well. And we can use 3D to help us do that. So here we have an interstitial ectopic, the first one, A, with the normal endometrium right here, and here's this ectopic out to the wall. And you can see that on this C-plane as well, that it's going all the way out to the myometrium. The interstitial line is helpful from the endometrium over to the ectopic, and here you can see this line in this patient that was 5 weeks, 4 days. Now, the interstitial line has been written by a couple different authors, and it appears to be highly specific and highly sensitive. And we're hopefully looking at that little interstitial portion of the tube. Now, this was the patient in B. And notice here on this transverse view that there is some myometrium here. So we always want to go back to our 2D images when we're looking at 3D pictures, because I think this is very misleading. We thought this was going to be an interstitial ectopic when we scanned it, but these pictures made us wonder whether there wasn't just too much myometrium and that it might be normal. So what do? You bring her back. This is a patient who was brought back 4 days later, and notice now that you take this picture of the endometrium, and that sac is definitely inside. It's not abnormal. It's not out here in that interstitial portion of the uterus. And if you take a rendered image of it, it now looks much more normal than it did on the first plane. So it's sometimes not easy to figure that out. Now here are two different women that have uterine anomalies. Which would you rather be? So the woman in A has a septate uterus with a gestational sac sitting out here in the horn at 5 weeks. And the woman in B has an arcuate uterus with it dipping down just a little bit here on this patient who happens to be 13 weeks. So most of us would rather be the arcuate, and let me tell you why. This patient first presented in A with bleeding at 6 weeks. And I just show you a normal endometrium just for you to realize what it looks like in comparison to this patient that has this big septum coming down the middle of it. Well, when she actually went on and did fine, ended up delivering at about 32 weeks gestational age, which is not uncommon that these patients with uterine anomalies deliver early with because the fetus just is ready to come out before. But she ended up with postpartum bleeding, and she had this large mass of echogenic tissue. And when she came in, I knew immediately that we needed a C-plane through her uterus to see the other picture and see whether there was anything in it. And retained placentas are very common in patients with septate uteruses. This patient actually had a manual exploration to get the placenta out at her at her delivery at 32 weeks, but still she ended up with retained placenta. Here's another patient with an arcuate uterus with a gestational sac. That's at about 6 weeks. But I didn't know if you'd even be able to tell she was pregnant. That's that normal for comparison. Now, there are multiple different uterine malformations, and most women are asymptomatic, and they occur in about 3% of the population. By far, the septate uterus is the most common. So when you see a uterine anomaly, that should be the one you're thinking about. The bicornuate, the didelphes, much less common. And this is the American Fertility Society's classification of uterine malformations. And I don't think it's important to memorize this per se. I think it's really important to realize there's lots of variations of how the uterus forms. And any one of these could be important for a patient who comes in with bleeding. She could have, something in this horn as well as the main horn that you're seeing, or whatever. So I think it is worthwhile, and we do go back to this chart on a routine basis when we're reading out cases. Now, why do we care? It ends up that these were patients that came for ovarian screening for other reasons not related to pregnancy. first trimester losses are more common in our subseptate uteruses than in our arcuate uteruses here. And you can see that we have first trimester losses in up to 42% of septates, in contrast to the normal population, which is 12%. Second trimester losses are more common in the arcuate ones. And then look at our preterm labor, more common in the arcuates, but still almost twice as many in our subseptates as in the patient that we discussed in this case who delivered at 32 weeks. Okay, which fetal head would you rather be, A or B? Well, A is, here's another patient with a same finding, cystic area, and A is a normal rhombencephalon, and B is holoprosencephaly at 12 weeks. Here's another picture of that cystic collection in the head, which is a totally normal structure at 8 weeks. So here's holoprosencephaly, and it should look like this normal butterfly appearance to the choroid. In contrast, this is holo. Okay, I've already talked to you about holoprosencephaly, so we're going to move on. This is a nuchal translucency screen. Would you rather be A, which has a nuchal translucency of 3.1, or B, 4.7? Now, I think most people would say they would rather be A than B, but it ends up that fetus A ended up with a hypoplastic right heart, and fetus B ended up being normal. Now, we do know that if you have an increased nuchal translucency, that you have an increased incidence of heart disease. And in this patient, you can see the left ventricle, but the right ventricle doesn't have any flow in it whatsoever. Now, let me just tell you a little tiny bit about nuchal translucency screening. Basically, we started doing this because some investigators in England figured out that if you added maternal age with nuchal thickness and serum analysis looking at HCG and PAP-A, that we could pick up to 87 or almost 90% now of trisomy 21s with only a 5% false positive rate. So they looked for abnormal karyotypes in patients with increased nuchal translucency, and this is a large study, 96,000 singleton pregnancies. They ended up with 651 abnormal karyotypes, and 50% of those are trisomy 21. 25% were trisomy 18 or 13, and 10% were Turner syndrome. 5% were triploidy, and 10% were other chromosomal abnormalities. So that is really what we're trying to look for. But fetuses with an increased nuchal and normal chromosomes still have an increased incidence of anomalies of about 7%. And I've just put this, if you want to know what they are, you can go and look at this paper in the American College of OB-GYN. But I've circled here cardiac because that is one of the ones that we are really screening for after we find this. How do we counsel patients with an increased nuchal? If they have an increased nuchal of different amounts, we look across. And so if she came in with a 3.7, we would say she has a 21% chance of chromosome anomalies, 3% chance of death, 10% of major anomalies, and a 70% chance of being alive and well after delivery. In contrast, if she has a 6.5 millimeter neck, she will be up at 65% chromosomal defects, 19% death, 46% major anomalies, and 15% alive and well. On the other hand, if you have a nuchal, it's elevated in the first trimester, you don't find anything, no chromosomal anomaly, and they come back and they have a normal fetal heart and a normal ultrasound exam in the second trimester, 95% of those babies are going to be normal. Okay, would you rather be fetus in A or B? And these are looking at the region of the nasal bone on fetuses that are being scanned for nuchal translucency screening. Well, it ends up that A has an absent nasal bone or delayed ossification. It's not really that there's no nose, it's just that it's delayed. And B has a normal nasal bone. So look at this region. This is just the skin. That is not the nasal bone. This is the nasal bone behind the skin. And notice that there's a normal tip at the end. So this just changes the screening results significantly. This patient was 35 years old. She had a nuchal of 2.6, which is within normal limits. if we call the nasal bone present, her risk is 1 in 263. If it's called indeterminate, her risk is 1 in 125. And if it's absent, we get a risk of 1 in greater than 5. This patient, it was missed on. She returned at 16 weeks. An absent nasal bone was found. She had an amniocentesis, and she had trisomy 21. Now, what can I tell you? The nasal bone should look like an equal sign. Notice the nasal bone in contrast to the skin. It should have a equal sign plus an echo at the tip of the nose. Okay, these are also 2 first trimester nuchal translucency fetuses, and what I'm trying to show you here is look at the MI and TI on these images, and I have blown them up right here for you to be able to see exactly what they are if you can't read them. But basically, fetus A has a TI of 0.2 and an MI of 1.2, and fetus B has 1.1 and 3.4. So what do you think? Well, the bottom line is that the MI and TI are output display standards that tell us about the power levels. The TI is the thermal index, the MI is the mechanical index. And the MI indicates the potential for ultrasound to induce inertial cavitation in tissues, and the TI expresses the potential for a rise in temperature at the ultrasound beam's focal point. Why do we care? Well, there are concerns for autism, for abnormal hearing, vision or language development, for intrauterine growth retardation, for childhood cancer, and for increase in non-right-handedness. Now, there was a study by Ang al. from Yale where they looked at 335 mice, and they used ultrasound for anywhere from 30 to 420 minutes, and a small number of neurons failed to acquire their proper position. They remained scattered within inappropriate cortical layers, and the authors thought that this could have consequences related to epilepsy, schizophrenia, and autism. We do know that lung hemorrhages in young mice and neonatal pigs occur with ultrasound, and intestinal hemorrhages also occur in adult mice, and that bleeding near the developing bone in young mice occurs. So we try not to use power Doppler in the first trimester unless there's a really good medical indicated reason. Approximately 250 million fetal ultrasound exams are performed each year in the United States, and to date, no adverse effects on fetuses have been reported. Ultrasound exposure can produce bioeffects at diagnostic levels in laboratory studies, and valid experimental studies are difficult to perform. So, we leave you with caution, advising us to use the ALARA principle, which we use for radiation, which is as low as reasonably achievable. So we do not use color or power Doppler in the first trimester unless it's absolutely necessary, and we try to keep our MI and TI below 1 if we can for as long as the study. Okay, which one would you rather be, A or B? These are both first trimester fetuses from 10 to 12 weeks. Kind of look-alikes. Well, A turns out to have a gastroschisis, and B turns out to be physiologic herniation, which is totally normal. So this is the normal bowel that goes out and back in during development. This is bowel that looks sort of finger-like projections, cauliflower-like, that is not normal. So the patient in B had these pictures of this physiologic herniation at 10 weeks and 2 days. And this is the cord coming in to the embryo. Here, with color Doppler, we have the fetus, and then here's the bowel herniation, and there's the cord going in. When we brought this patient back at 12 weeks, you can see that it's back inside like it's supposed to be. So that's a totally normal finding. In contrast to this fetus with gastroschisis that has this multiple finger-like projections, and when she came back at 19 weeks, you can see these bowel loops outside, and that's the normal cord insertion into the belly of this fetus. So Dale Sir was a sonographer, the chief at the University of Washington for many years, and he noticed this and actually wrote this paper, and I love showing this picture of the bowel herniation going out here, and it should be back in by the end of the 11th week. Would you rather be A or B? Well, A is a cystic adenomatoid malformation, and B is chaos, which is chronic high airway obstructive syndrome. And this happens when you have an obstruction at the larynx or the pharynx. So notice that this lung is too echogenic in comparison to the other side, and that the heart is pushed over. Notice that this fetus has bilaterally echogenic lungs with a very small fetal heart in the middle. And there's actually two bright black areas here. That's called the bow tie appearance because it's the bronchi filled with fluid. And this is a normal chest for comparison. Now the first fetus in A has this large echogenic mass that when you turn on it, you see that it's in the lower portion of the lung. And that is something that we went on and did MRI in this case. Here you can see the mass with abnormal signal here, suggesting collapsed either CAM or sequestration. And here you can see it in this coronal view, and these are the normal lungs on either side. These are T2 images where the fluid is bright. And this is the chest x-ray on this fetus after birth. Actually, now it's a neonate. And you can see the chest, the heart here, and there's really very little on the x-ray to see. Here you can see just a little bit of the stranding. Very subtle findings for this patient with a cystic adenomatoid malformation. Now we do CTs or MRs to look at these to see the vessel. Today we'd probably do an MR if we had the opportunity because of a radiation dose. But the truth is we used to operate on all these so these kids wouldn't get infections, but now our surgeons are being more conservative and they're watching them, and unless they get multiple infections, they're not operating anymore. That's in contrast to chaos, the chronic high airway obstructive syndrome, where we see large echogenic lungs that are everting the diaphragm, pushing it down like balloons, so that when you look in section through the axial picture with the spine over here, I'd probably be around at this level right there. They look almost like large echogenic kidneys, but they're really the lungs pushing down into the belly. And you can say that this fetus also has ascites as well, and that once again, that heart is very, very small. And that's a pretty classic appearance for chaos. Okay, these are 4-chamber heart views. And I'm going to take B and rotate it for you so it's in about the same orientation. So A turns out to be normal and B turns out to have an AV canal. And the main finding here is that the AV canal is a single valve that is at the same level, whereas in a normal 4-chamber heart, there's an offset between the two valves, the tricuspid valve and the mitral valve. This is the left atrium, left ventricle, right atrium. Spine's back here. So the normal 4-chamber view has that normal offset of the apex. And you can see here the valve is just a little bit inferior to this side. And that's very important in identifying the 4-chamber. So this patient was a 37-year-old with a positive trisomy 21 risk of 1 in 22. And she had an ultrasound at 20 weeks and at 28 weeks that were called normal. And at 34 weeks, she came back and an AV canal was identified and she ended up with trisomy 21. And let me tell you what go back and look at these pictures. It's not so obvious. The only real finding is that we could see no offset on this valve. When we put on color, that didn't help us. Usually you would think there'd be a lot of color in the middle of the heart. We didn't see it. Clearly on this 28-week scan, it is a single valve. It looks like a single valve going across, and that there's probably a defect here and here. But the coronary sinus lives right behind here, and sometimes I've overcalled AV canals when it's really the coronary sinus. Again, a case here, you don't see what we expected to see, and on our LVOT, you often will see your VSDs, but you do not see it in this patient. It looked normal. When she came back at 34 weeks, you can see this hole in the middle of the heart, and indeed, that is an AV canal. So this is the final picture. Would you rather be fetus A or fetus B? Well, this is a trick because this is the same fetus. I think the fetus in A looks like a conventional little fetus, you know, in fetal position, his little hands up here, little feet here. But in fetus B, in the picture in B, I think it looks like an old man that looks like he's trying to take a leak and go to the bathroom. Thank you very much.